Mundra.
Hi everyone, my name is Vatsala Mundra and I'm a third-year medical student at UT Southwestern. Thank you to the Texas Society for Clinical Oncology for giving me this opportunity to present our research on systemic immune parameters after prior radiation therapy in patients receiving immune checkpoint inhibitor therapy. So I have no competing interests or disclosures, and this research was funded in part by many institutions, so thank you. All right, so for a little bit of background, despite high-level interest, there's not a lot that's known about the mechanistic links between ICI, or immune checkpoint inhibitor therapy, and radiation therapy. So there are clinical observations and preclinical models that have suggested a link between radiation therapy, or RT, and anti-tumor immune responses. These links depend on intact immune function, and focused radiation therapy appears to heighten immune function. We also have something called the abscopal effect that has been hypothesized, in which, in some cases, local radiation therapy results in tumor shrinkage at sites that are far away from the treatment field itself. There are also links that are being studied between immune checkpoint inhibitor therapy and radiation therapy. So, for example, in one study, radiation therapy prior to the start of ICI, using particularly anti-PD-1 antibodies, enhanced treatment efficacy. In another study, PD-L1 therapy after concurrent chemoradiation for locally advanced non-small cell lung cancer significantly improved both progression-free and overall survival. However, in the clinical setting, numerous trials of ICI and radiation therapy have yielded discouraging results. And we hypothesize that this may be because of inadequate mechanistic understanding of the links in the clinical setting. So our overall objective in this study was to characterize systemic immune parameters in patients according to their receipt of radiation therapy prior to starting ICI. To do so, we collected blood samples in patients before they started ICI and 6 weeks after ICI had been initiated. We also took a look at clinical data, including information such as demographic data, the type of cancer, the type of ICI therapy they received, and the date of ICI initiation. We also took a retrospective review of electronic medical records to identify radiation therapy exposure, whether or not they had gotten radiation therapy, the indication for radiation therapy, fractions, dosage, and dating as well. And to analyze everything, we used Fisher's exact test as well as t-tests and generated heat maps of cytokines and autoantibodies to understand increases or decreases in levels after initiation of ICI. The inclusion criteria for our study to be enrolled in the ICI database was patients that had been planned for but not yet started ICI therapy. They could have any cancer type or stage, and any checkpoint inhibitor therapy was included, as well as monotherapy, combination therapy, or combined with other types of treatments, such as chemotherapy and, of course, radiation therapy. We had a total of 277 patients in our cohort, and 25% of our patients received radiation therapy within 6 months before starting ICI. Total, we had 40% of our patients were women, and 76% were non-Hispanic whites. The most predominant type of cancer in our study was lung cancer with 51%, and second was melanoma at 22%. So, talking about our results, there were a few cytokines and antibodies that were associated with prior radiation therapy exposure. Out of the 40 tested cytokines, fractaline, or CX3CL1, and CCL15 were found to be elevated from baseline. And in terms of 125 autoantibodies that were tested, anti-complement C8 and anti-JO1, nucleosome, and GP2 were found to have changes as well. So taking a closer look at our cytokines, CX3CL1 levels were significantly higher in patients who had received radiation therapy at least 6 or 12 weeks prior to ICI initiation. However, patients that received radiation therapy closer to ICI initiation did not have an increase in their levels. Similarly, CCL15 levels were higher in patients who had received relatively recent, so again the 6 to 12 week mark, radiation therapy, and this was primarily driven by stereotactic-based radiation therapy in the particular case of CCL15. And again, we saw that patients that received radiation therapy closer to the start of ICI therapy did not have this increase in levels. Talking about antibodies now, anti-complement C8 antibody levels were higher with near-term prior radiation therapy. So again, the 6 to 12 week mark. And we saw dynamic changes, so not from baseline, but changes overall in the antibodies JO1, GP2, and nucleosome. So taking a look at JO1 and GP2, we saw that there were lesser increases after the start of ICI initiation if patients had received radiation therapy, while in nucleosome, there were increases or greater increases in after ICI initiation in patients that did receive radiation therapy. So taking a look at the biggest cytokine changes and the biggest antibody changes, what do we know about these particular immune parameters? So CX3CL1 is a member of the CX3C chemokine subclass, and it's known for its chemoattractivity for monocytes, neutrophils, natural killer cells, and T cells. And preclinical models have suggested that this is a particular way in which radiation therapy interacts with the innate immune system. And complement C8, which is a late complement factor in the formation of the membrane attack complex, which I'm sure many of us remember from medical school, is used to target and lyse pathogens and contribute to tissue damage when directed against host cells, which may play a role in how radiation therapy impacts tumor cells and tumor decrease in function. So taking a look at the limitations of our study, the role of radiation therapy on immune function is a big limitation. So radiation therapy may affect cell populations and functions and immune parameters, which we weren't able to study or we did not study, as well as radiation therapy biologic effects may occur in the tumor microenvironment and so may not be seen in the peripheral blood draws that our study depended on. For this, we would need biopsies of those particular target organs in which the radiation therapy was directed towards. Another limitation was the heterogeneity of our study cohort. So with patients having different types of cancer, with having different types of ICI therapy, and as well as different reasons for radiation therapy indications, as well as different regimens. So overall, in a cohort of patients treated with immune checkpoint inhibitor therapy, the administration of pre-ICI radiation therapy with varying timing, schedules, and indications was associated with few differences in cytokines and autoantibodies. So we need further research to understand and elucidate the biologic effects of this strategy in order to optimize and understand the rationale behind combining ICI and radiation therapy in the clinical setting. Thank you.